This is a case where we removed a tumor. The tumor was eroding through the base of the brain, called the diaphragma, up into the what we call the suprasellar cistern. And we thought that we had pulled out all of the tumor. We thought that we had it all out, but we weren't quite sure. And so what we then did is we advanced the endoscope. So we now are looking in. This is where tumor used to be, where the endoscope is now. And we're actually looking up into the brain. We then look further, and this is actually the optic nerve that we're seeing with the endoscope. And you can clearly see we don't have any tumor on it. And this little guy right here, that's the pituitary stalk. So we also see there's no tumor left on the pituitary stalk. This is something that we just can't see with other technologies. It makes the endoscope superior for our purposes. Dr. Shahanian, who's a neurosurgeon out in California, actually did a study about 10 years ago where he was doing pituitary surgeries, and he did them all transsphenoidally. Removed all the tumor, and then when he was done, he said, okay, I'm going to put an endoscope in there and look around and see how many patients I still find tumor in. 33% of the patients that he thought he removed out all the tumor with a microscope, he found more tumor with the endoscope. Usually it was sitting lateral beyond where the microscope could visualize. He then did the same study where he used an endoscope up front and then afterwards used the microscope. And in none of those cases did he find that the microscope found tumor that he didn't already see with the endoscope. So it was a pretty good study, kind of convincing a lot of people that maybe we should start using endoscopes for these surgeries. This was over 10 years ago now. As we start to become a little more fancy and we get away from straightforward things like pituitary tumors, we start talking about clival tumors, and tumors are going higher up into the brain, we have to be a little more concerned about the cranial nerves. And so neurophysiological monitoring becomes very important. And we often use SSEP, EEG, brainstem auditory evoked responses, cranial nerve monitoring. We also use Doppler ultrasound to help identify the carotid sometimes intraoperatively, again, to make things safer. When we create these big holes, we have to find a way to plug them up. And we use different forms of glue. The patients love it when they're told that they're going to have glue put in their nose. But we use Tissio, which is a form of fibrin glue. It forms a clot and helps seal off the hole that we saw in that video earlier. We also have a glue called BioGlue that we'll use on occasion, and we also use a glue called DuraSeal. All of these are polymer-based products that you basically can squirt on neural structures, not cause any damage to those structures, and provides a fairly good watertight seal to prevent spinal fluid from leaking in and out. We also have multiple different grafts. We have autografts, which I'll show you in a little bit, but we also have a lot of allografts. One of the things that we use quite often is called Duragen. Duragen is an artificial brain liner made of collagen that you can use to reconstruct the lining of the brain with, the dura. We also can use fascia lata or pericardium, what we call DuraGuard, to act as artificial liners as well. And what happens is the body heals, it replaces those structures with the normal cells to become a scar. This is just an image of the different types of glues we're using. This is the Duragen, which is the artificial brain liner. It's basically collagen. And these glues, basically you just squirt them in as a liquid. You count to about 3, and then all of a sudden they're like a gel. They kind of hold in place. This is kind of a typical picture that we'll have once we've done removing these tumors. For some of the ENTs who are in the room who have done transsphenoidal surgeries, you'll probably notice this is a much bigger opening than you're probably used to seeing. Usually with the traditional transsphenoidal opening, it's about 1/3 that size. We make much bigger openings. The bigger the opening we make back there, the more likely we're going to find everything that we want to find. Also, less likely that we're going to injure something that we're not seeing. So we end up having a bigger opening. Here's where there was a hole in what's called the diaphragma of the skull base. So we put a little patch right where that little hole is. We then reinforce it with another layer of what we call Duragen. We put another layer over that, so we're sandwiching things now. And what we're doing is we're isolating the brain from the sinuses, which are not sterile. We then put the glue in. We then sometimes put another layer of lining on top of that if we need to, or use a different type of lining. In this case, this is alloderm that we were using. And then sometimes we'll put a balloon in the back of the nose to hold everything in place if we need to. Now, we often don't have to put all that stuff in most of our cases. For the more complex, very large defects, we do, and we'll keep a balloon in the patient's nose for probably 3, 4, or 5 days. They can breathe through their nose. The balloon is way in the back, so they're able to breathe fine. It doesn't really hurt them by having the balloon in there. And in 3 or 4 days, it's a Foley catheter. It's all that's in there. It's a 5 cc Foley catheter. We deflate the balloon, we take it out. Someday, we hope to be able to sew in these areas, but right now, we don't have the technology. Hemostasis is also very important. When we started doing this surgery in the late 1990s, the biggest criticism in the field of neurosurgery is what happens if you hit a blood vessel and you have bleeding. You have no way of controlling it. They didn't make instruments that would go all the way in the back of the nose to help stop coagulation. And so now, in the past 10 years, both ENT and neurosurgery, we have lots of different devices that we can use to stop bleeding. We have hemostatic agents, so the classic way to stop bleeding is just to hold pressure. We have little things in there that we can use to hold pressure if we need to. We have bipolar electrocautery and monopolar electrocautery and all these other different things to coagulate blood vessels to stop bleeding that all fit in the nose and go all the way back. So why endoscopic? Well, by just going through the nose with no incision in the front, there's no cosmetic issues. There's no incision in the front of the nose or under the lip. There's less pain or discomfort after surgery. We generally don't need any packing in the front of the nose that's going to prevent them from breathing. The procedure is generally a shorter duration. You don't have to put a retractor in the nose. The scarring is usually a little bit better as well, unless you are doing what we call an expanded and a nasal approach. We don't use any radiation when we do the surgery like you do with the regular transsphenoidal approach. And we have a better view of the cavity to remove the tumors. Well, around the year 2000, lots of people started to do endoscopic pituitary surgery. And this is kind of a list of all the fathers of pituitary surgery, starting with Theodore Krauss, who in the 1800s was the first one to ever biopsy a pituitary tumor. The first person to really do resect a pituitary tumor through the nose was Harvey Cushing. And then the person who's kind of considered the father of pituitary surgery is a guy named Ed Laws, who has done over 5,000 pituitary tumors, was in University of Virginia, now is at Harvard and is retiring. But it's the guys at the bottom here who really have been the innovators in the past 10 years. These are the guys that have now taken endoscopic surgery to the next level. This is Haedong Jo, who's a Korean neurosurgeon in Pittsburgh. Paolo Capabianca, who's in Italy. Giorgio Frank, who's an ENT that works with Paolo. And then Amin Kassam, who used to be in Pittsburgh and is now in California. These guys said, well, if we can remove pituitary tumors through the nose, why can't we do other things through the nose? And so they started to do that. They started to look at tumors like this and said, well, why can't we use these same tools that we now have and go up higher into the brain and go deeper and kind of push the envelope to see what we can do? And so they started to do that, and they created new instruments to be able to get to these areas. And so to get to these areas, you actually have to use an expanded and a nasal approach. They also said, well, what about reaching other areas of the brain? What about the pineal region? And started using intraventricular endoscopy to biopsy other lesions inside the brain instead of just going through the nose, using other portals as well. So the next evolution was the expanded and a nasal approach. And that approach essentially is the same approach as what we've talked about now, but going a step beyond that. With the pituitary tumors, we're focusing right in this area. Well, as you can see with the endoscope, you can see a much larger area than that, and with the expanded and nasal approach, you actually utilize that ability. You use angled endoscopes. You start looking upwards or downwards or to the sides, and you start opening bone in other areas of the skull base to get to other areas of the brain. By utilizing this, you now can reach the entire skull base, and you're not limited to just what we call the sella. So now we can start talking about things like frontal sinus tumors, meningiomas, chordomas, clival tumors, lots of other things that no one would ever think about removing through the nose 10 years ago. The setup for it is identical as what we would do for an endoscopic pituitary. The approach is the same. The endoscope is through the nose using binaural technique. Once you go in there, you reflect the turbinates. If it's a very large tumor, you have to go lateral. Sometimes you'll remove some of the turbinates to get your access. Sometimes you have to go into the maxillary sinus to get to where you need to go. But the bottom line is you want to find the sphenoid sinus. The sphenoid sinus is the workhorse of all of these procedures. And so what we do is we basically broadly open the sphenoid sinus. So again, this is a typical view that we'll have once we've opened up to the back of the brain. And you can see all kinds of structures here. We have a diagram on the side to help. But this is the sella. Here are the optic nerves. This is called the planum sphenoidalis. So now we're looking at the anterior cranial fossa. Here are the carotid arteries and the cavernous sinuses. Here's the clivus. Here's the rostrum. And if we open this up and go further down, we're going to be towards foramen magnum and jugular foramen.